Hello, welcome back to Student Nurses Success. Today we will talk about some common motor and neuromuscular disorders in a two-part video series. As always, you can obtain a copy of the completed concept map at our Etsy site. The link is in the comments section. So let's get started. And at the end of this two-part video on motor disorders, your completed concept map will look like this. Part 1 of the motor will cover multiple sclerosis, Guillain-Barre, Myasthenia Gravis, Muscular Dystrophy, and Parkinson's. Part 2 will cover spinal cord injury, cerebral palsy, and ALS. So here is our blank map in order to begin. The first disorder we want to talk about is multiple sclerosis. Multiple sclerosis is considered a chronic disease. In this chronic disease, there is demyelination in the central nervous system, and that's important. This often leads to significant disability, although there is variation in the course of multiple sclerosis, where some may have more disability than others. Symptoms can also vary widely. Multiple sclerosis affects women more commonly and frequently between the ages of 20 and 45 years of age is when it's diagnosed. The etiology is unknown, but it does seem to have a higher risk profile for those who live in the northern latitudes of the world. There may be a genetic component, but that is not well understood. We also think infection or environment may play a role. With multiple sclerosis, it is considered an autoimmune or an immune-mediated disorder, which causes inflammation of the myelin sheaths. The myelin sheaths that are affected are in the central nervous system. The inflammation leads to scar tissue development in the sheaths, which then alters the nerve impulses and transmission of the nerve signals. The course is unpredictable with exacerbations and remissions. So patients may have some good days and some bad days. We think these exacerbations and remissions may be caused by stress or illness. Again, the manifestations vary widely, and they include weakness, poor coordination, unsteady gait, vision changes such as blurry vision, and commonly, patients have paresthesias, which are tingling sensations throughout the body. They may also have memory impairment, they develop tremors, and as time goes on, they may lose bowel and bladder control. The diagnosis of multiple sclerosis is usually through MRI. And in the MRI, they can identify lesions or plaques from the scar tissue that has developed. Treatment is focused on reducing the immune response using things such as steroids and immune-modifying drugs. Guillain-Barre is another disorder that causes inflammation of the myelin. However, Guillain-Barre has an acute onset, and it affects the peripheral nervous system. Guillain-Barre is a common cause of non-traumatic paralysis. Meaning patients develop paralysis, but they've had no injury to their spinal cord. The etiology is not well understood, but it often follows an upper respiratory infection or a virus such as gastroenteritis. With the pathophysiology of Guillain-Barre, there is demyelination, and this is due to T or B cell mediated responses. And again, that means that's immune-mediated pathology. The inflammation from this B or T cell mediated response causes inflammation of the myelin of the peripheral nerves. And what we see is a rapid onset of weakness. This rapid onset of muscle weakness starts in the lower extremities and moves up the body. It may go halfway up or all the way up, causing the need for ventilatory support. So what we have is a progressive ascending paralysis. And the height that it goes up really just depends. Some individuals may have problems breathing. Other individuals, it may only go halfway up the body and then go back down. So they may require ventilatory support. The manifestations peak in about 10 to 14 days. And it does tend to resolve with the return of function in most cases. However, patients may require quite a bit of supportive care during the paralysis phase. Treatment often includes IVIG infusions, or even plasmapheresis. And remember, after the recovery period, some may require some additional rehabilitation to gain back the strength they have lost. Myasthenia gravis is our third immune-mediated disorder. It is a chronic autoimmune disease that disrupts the communication between nerves and muscles at the neuromuscular junction. It affects women more often and starts about the age of 20 to 30 years of age. In myasthenia gravis, acetylcholine receptor antibodies are produced, and this leads to the destruction of the acetylcholine receptor sites at the neuromuscular junction. This causes a defect in the nerve impulse transmission. Manifestations include profound muscle weakness and fatigue, the onset is very insidious and usually affects muscles of the eyes, face, mouth, and throat first. And then we start to see limb involvement. One of the things that we do see fairly frequently is something called ptosis, which is a drooping of the eyelid. Treatment works fairly well and includes the use of steroids and anticholinesterase inhibitors, which help reduce the breakdown of acetylcholine in the synapse. Now, patients can develop a myasthenia crisis, and that can be from a stress or illness event, and that may require additional supportive care during that time. And that additional supportive care can even include ventilation. Muscular dystrophy is our next disorder. Now, there are many different types of muscular dystrophy, and Duchenne's muscular dystrophy is the one I'm going to talk about. It's one of the more common types. And we'll call that DMD. DMD is an X-linked disorder that causes progressive deterioration of skeletal muscle. Since it's X-linked, it primarily affects males. In DMD, the muscles actually start to deteriorate and atrophy. There's really no problem with nerve communication, but the signaling just doesn't do anything because the muscles are deteriorating and cannot respond to nerve communication. Onset is somewhere about the age of 3 to 4 years. And this is where children start to lag behind in gross motor milestones. While other children are running, skipping, pedaling bikes, climbing, the child with Duchenne's muscular dystrophy is lagging behind and is unable to do that. Their hip muscle groups are weak, and they usually have trouble getting up from the ground and even have to push themselves upright using their arms since their legs cannot power them up. This is called Gower's sign. As DMD progresses, the weakness starts to include respiratory muscles, cardiac muscles, and pretty much all muscle groups. There really is no cure, and it's diagnosed by a muscle biopsy. Or, if it's Duchenne's or another type of genetics, muscular dystrophy, you can do a genetic profile. The goal is really to maintain mobility and quality of life as long as possible. And most children with Duchenne's muscular dystrophy live into their early 20s, but usually not beyond that. The last disorder that we're going to talk about in this video is Parkinson's disease. And this picture here is supposed to kind of help give you a visualization of Parkinson's disease. Parkinson's disease is a chronic disorder of dopamine deficiency. And that dopamine deficiency is in the basal ganglia. Now remember, the basal ganglia is responsible for movement control, such as starting, stopping, and even monitoring movements executed by the cortex of the brain. There are different types of Parkinson's, but the most common is the idiopathic form, which has a slower onset and is more common after the age of about 60 to 65 years of age. The cause is not well understood, but it may have an environmental or a genetic component as well. In Parkinson's disease, there is degeneration of dopamine neurons in the basal ganglia. And what that leads to, that dopamine deficiency, means that there's less signaling and motor impairment. It may be linked to oxidative stress causing mitochondrial dysfunction. We also know that Lewy bodies have been found. And Lewy bodies are abnormal clumps of protein. We see Lewy bodies in other disorders as well, other types of brain disorders or degenerative disorders. Manifestations of Parkinson's includes fatigue, tremors, even something called pill rolling, where they're kind of rubbing fingers together, loss of flexibility, and an increase in rigidity. In fact, we even call it cogwheel rigidity, where their movements are very rigid and not smooth. We see bradykinesia, or very slow movements, mask-like facial expression, shuffling gait, and monotonous speech. Eventually, we start to see the development of dementia, drooling, and that leads to increased aspiration risk. We see a deterioration of all movements and decrease in the ability to perform activities of daily living. Now, there is no cure, but increasing dopamine precursors in the form of levodopa has been helpful. However, the dose of levodopa usually needs to be continually increased over time, and eventually the side effects from the from the medication can actually start to affect quality of life. And so we have it. We're a little over halfway through the motor disorders. Motor Disorders Part 2 video will cover the topics of cerebral palsy, ALS, and spinal cord injury. Thanks for joining me today, and remember to like and subscribe for more pathophysiology videos.